Okay, hello everybody. Okay, hi, I'm Saumitra Deb. I'm an honorary clinical professor of neuropsychiatry at Imperial College London, and I was a clinical professor of psychiatry in a full-time job at the University of Birmingham for a long time before taking an early retirement and moving to London a few years ago. And this is my colleague Bharati, who works on this project that we are going to talk about.
Hi,
And she
everyone.
has actually, so yeah, you said hello, Bharati? Yeah, okay,
I
okay.
did.
So
Am
that's
I mute?
Bharati.
Oh, no, I'm on mute. Yeah.
Okay.
Hi.
And you will see when I do the presentation what a mammoth task she has achieved, the amount of work gone into this web page that we are going to show you in a moment. So plan today is for us to present to you this training program that we have developed. But I'd like to thank Robin and Alan for inviting us today to give this talk. This training program is called Spectrum in short, is designed primarily for staff who are looking after people with learning disabilities in the community setting. But you will see when I do the presentation that it has a very wide remit. So it could be useful to a very wide range of stakeholders, like family carers, community learning disability members, even the doctors, and so on and so forth. And the idea of developing this is to really help to implement STOMP, and you'll probably all be aware of the STOMP pledge from NHS England, and I'll touch on that very quickly. And this is an NIHR funded project, and it is sponsored by a local trust in London, Central Northwest London Trust, and is based at Imperial College London. So the idea of this training really is to change the hearts and minds of support staff and other stakeholders, really to change their attitude toward use of medication when it comes to addressing challenging behavior. I'm using the term challenging behavior as a shortcut. I know a lot of people would probably like the term behaviors that challenge or behaviors of concern, but I'll just keep on using challenging behavior as a shortcut. And sometimes I might use the term intellectual disabilities, which is same as learning disabilities, a bit academic, the intellectual disability. We did actually present this in a pre-recorded session in a national Australian Congress of National Disability Society, which was attended by more than 1,200 people. And it became so popular. Of the 35, 40 presentations in that Congress, ours was the most popular, and we were inundated with emails. And their CQC equivalent there, NDIS, they're now very keen to roll this out in Australia. So I hope it catches up here as well. So I have a few slides to start with, maybe 20 minutes on this, and then I will show you the actual site. So hopefully it'll be a quick guided tour of the site to show you what's there. There's a huge amount of research you will see in a moment. It's like an encyclopedia or a Wikipedia, and you move from one section to another very quick, very easily. And then I will take you through one module, core module on medication, and take you through various aspects of it. And then I will hand over to Bharati. So maybe I'll take 40 minutes to do that and then hand over to Bharati. And Bharati will take you through another core module, which is about the alternative to medication. And I'll just talk about the medication and STOMP module. And then when Bharati does the presentation, Robin has an actual real life case to talk about. We usually make this very interactive, but today in 2 hours time, we're going to present what we usually present in 2 full days and then additional time. So we'll see how much interactive it could be, but people could chip in when you talk about various case studies and so on and so forth. So with the slides, to give you a bit of background about Spectrum. So it's the why, who, how, and what of Spectrum. So basically, why did we develop this training program? Who were involved in developing the program? and how did you develop it, and what's in there. So what is the last one is the most important, which, as I said, I'm going to take you through. As I said, it's all designed to really help with the STOMP project and to reduce the over-medication of people with intellectual disabilities, which is a major public health concern, and you will all know about it. I won't go through all these points in this slide because you're all familiar with the problems of over-medication. Again, in next slide, I won't go to the causes of challenging behavior because that we will have that in the actual module. But when it comes to prescribing, and I see it that the two main protagonists in the psychotropic prescribing process are the support staff and the prescribers, so the psychiatrists or the doctors. And the doctors keep blaming the support staff, saying that, well, they come to us looking for a magic bullet, and what can you do in our clinic, which is prescribe. And then the carers blame doctors, saying that, well, doctors might be too trigger happy with their prescriptions at times, and they don't look at all the options in a more person-centered way. So it's a question of really educating both these groups, and we have started with the support staff. Now, STOMP, as you all know, it's an NHS England initiative. It started about 5 years ago. But one thing to talk about STOMP, that we, our own study and other studies have shown that although it was launched 5 years ago, it hasn't been that effective in reducing the over-medication, which is the central to its aim. And although the doctors are probably prescribing or initiating less often antipsychotic medications, but instead some are prescribing more other types of psychotropic medication like antidepressants. But often they're not really withdrawing medication even after many years of use. So something like this Spectrom initiative or the training is really to help implement STOMP and its objectives. Who were the people involved? All the stakeholders you can think of, people with intellectual disabilities, their families, support staff, service managers, GPs, psychiatrists, community learning disability team members, community pharmacists, and representatives from social care service provider organizations. I'll show you in a moment different organizations who were involved, including yours, Robin and Alan, and how we had a core project team and then the project management team, and then we developed a Spectrum development group, which is basically representatives of 12 or 14 stakeholder groups. And then we had a learning disability advisory group who kept giving us feedback on the development of the project. And then we had an external reference group of about 24 stakeholders who, once we have developed the draft Spectrum, they provided feedback on that, and we just amended Spectrum based on those feedback. And then we had a steering committee to oversee the whole project. How we did it, we looked into the literature around this, and then we initially ran 4 focus groups. There were 2 groups, but each group had 2 focus groups. One consisted of service support staff only, and the other one consisted of service managers and trainers from various organizations, including Robin, who was in that group. And we had 2 meetings. In the first meeting, we talked about all the issues relating to medication use when it comes to addressing challenging behavior. And in the second meeting, we talked about how to address these issues. And if we develop this training program, what should be the content and the format of the program. And then we had a one-day co-design event. We had about 24 stakeholders there. We divided them up in 6 different groups around the table. And each table we had different stakeholders, parents and doctors and nurses and support staff and so on and so forth. And each of them dealt with a particular theme and then developed the contents, including case studies for each of these themes. And then all this evidence from literature review focus group one day co-design event. They were all put together and discussed in the Spectrum development group meetings. And then, as I said, we developed the first draft and had feedback. And we did run a field testing. Bharati did an amazing job during this COVID. It was very difficult to run the field testing, but eventually we managed to train 20 staff, and 4 trainers were involved, involving one from Australia. And the feedback we have received is very positive, and some quantitative analysis we have done on the knowledge and the attitude towards behavior from the support staff. They showed change which was statistically significant, which is good. Now, what you have in this not STOMP, it should be Spectrum on the top. Anyway, what you have there, the web page, we have 14 modules, and they're online, but there are some that could be used face-to-face. When it's a face-to-face nowadays, you can use a platform like today's platform, virtual platform, to train others. It doesn't have to be face-to-face in the literally sense. We have 2 core modules. We'll discuss that. One of them is medication, or STOMP core module. Another one is alternative to medication. So we tell staff about the medication, when they could be used, when they shouldn't be used, their side effects, and so on and so forth. So it gives them, it empowers them to ask questions to the prescriber. So why are the medication used? If they're used, could they be withdrawn, and so on and so forth. And then we also tell staff about the alternatives to medication to address distressed behavior. This is actually based on PBS and person-centered principle, but we approach it in a very different way from what Robin would probably do and Alan would do as a PBS practitioner. And then we have a huge amount of resource, internal and external. And within the internal resources, we had 32 accessible psychotropic medication leaflet for people with intellectual disabilities. Now, these accessible leaflets on medication were first developed by my team when I was a full-time professor in Birmingham almost 16 years ago. And that was the first of its kind, which is available free of charge to be downloaded from internet. And since then, various other organizations actually copied this and developed their own. So we have updated those that we developed 16 years ago. Modules, as I said, 2 main modules are, the core modules are medication, and ATM, alternative to medication. And these 2 are presented in a face-to-face one-day session, each of them. Within each of these core modules, you have other modules like medication review module or STOMP action plan. Now, this is very important, and I'm going to spend some time when I show you the actual Spectrum site on this, because the idea is to encourage support staff to run their what you call in-house staff-led medication review. This is not a formal review that the doctors will do, but these are to discuss about the issues that are related to medication use, and to go prepared to the clinic with all the right information and also the right questions to ask the doctors. Because it is not uncommon for us as doctors to see somebody coming to the clinic who is maybe a temporary staff who doesn't have a clue what's happening, and then they don't even know what medication the person who they have accompanied are on. So that becomes very difficult for us to really take any action. So it's really to educate and empower people to go through this checklist, which I will show you in a moment. And then other modules we have under medication is medication withdrawal review, assessment of behavior is another important module, and effective liaison with family carers and advocates, and effective liaison with professionals. These are quite important modules there. And under alternative to medication, we have communication issues and effective engagement with and support to the person with intellectual disability. That's another very important module. Other modules are psychiatric disorders and their relationship with challenging behavior, physical disorders, a very important module, and challenging behavior, ASD, another important module, and ADHD. And we have resources like CATS, is the comprehensive assessment of triggers for challenging behavior scale. This is a comprehensive, very long list of triggers that support staff can use during their functional analysis. and I will show you that. Yellow book is like a health passport. Many organizations will have it, but if you don't, then you can use this template. Accessible leaflets on psychotropic medication I've talked about. I'll show them to you. And other things, we have training manuals. So for these two core modules, we have a very detailed, comprehensive training manuals. And if anything is too prescriptive, it tells you when to take the lunch break, when to take the coffee break, and so on and so forth. But it takes you step by step to actually, if you want to do the training yourself to your staff group, you can just take it off the shelf and use those manuals, very detailed manuals, how to actually provide the training. And then we have some MCQs for staff to really check their knowledge once they have actually completed the modules. And the format of the training is, I'll show you in a moment, that we start with the learning objectives, then we usually present a case, and then we have some discussion. And we ask a question and then have some discussion, and then we go back to a model answers that we have prepared, and then have some more discussion. And then at the very end, we have the summary points. We have video clips. We have some tasks and activities for the trainees to take part in, so that keeps them busy and occupied. Lots of handouts. We have quotes from the focus group, and hyperlinks to other external and internal models, and then some homework. So the idea is to really encourage discussion as much as possible during the training. Let the participants think about the issue. So it's not what you call didactic training, it's more interactive. Let participants draw from their day-to-day experience. And this is not for a one-off training. We don't want this to be just one-day training like it happens in many organizations and then forget it. This we'd like people to use as a source of reference. So for example, if you're talking about person-centered planning for a person who has autism, and it is a big module on autism, you go and check out what the symptoms of autism are, how to help people with autism, and so on and so forth. If you're talking about a particular medication, you go to the accessible medication leaflet side. If there is a suspicion about a psychiatric illness, or maybe the doctor said this person suffers from bipolar disorder, so you don't know what bipolar disorder is, you go into the physical disability module and find out a bit more about bipolar disorder. And the same with epilepsy, physical problems. There's lots of resources, and it explains every possible things that you come across in your day-to-day practice. So the idea is you use this training program as a reference point. It's possible to keep printouts of all the documents handy, so during your staff meeting, you can just refer to them as you go along. These we will show you, so I'm not going to take you through all of them because Bharati will take you through some of these ATM sub-modules. As I said, the alternative to medicine module is based on PBS principles and person-centered care, but presented in a different way. So Bharati will start with a case study, and then we'll talk about staff's immediate reaction to challenging behavior. And then we'll expand on the case study and discussion and see how staff's attitude and behavior can change as they understand the person better and understand the behavior better. Then it goes into triggers for challenging behavior and assessment of behavior. We use this BMPPS model, but there are other templates you can use. And the BMPPS stands for the behavior itself and how to assess the behavior, the medical causes of behavior, the person with intellectual disabilities, so it's 1P, the sensory issues, communication issues, etc. And then P, another P stands for psychological and psychiatric causes of behavior, and then social and environmental causes, a huge chunk there. Then it goes into understanding the person with intellectual disability, how to effectively engage with them. There is a section of intensive interaction. We put optional against some of these in the manual. If the trainer runs out of time, they can skip these. And then ATM is divided into 2 sessions. In session 2, we discuss about staff's own stress, particularly in reaction to challenging behavior and how to handle them, various factors affecting stress and so on and so forth. And at the end, we have a 5-minute body scan meditation with printed scripts, but this is just a taster, and they are encouraged to explore other ways of doing meditation using mindfulness and so on and so forth. And then the medication, I'll take you through these. It starts with the typical prescription, and we discuss about different classes of psychotropic medication, their side effects, the investigations necessary for each class, and why should you worry about over medication. And this bit about medication review, what to do in the review and to go through the checklist, and information to take to medication review in a clinic or a GP surgery, what questions to ask the doctor in the clinic, medication withdrawal, effects of withdrawal, side effects of withdrawal, including resurgence of challenging behavior, and as I said before, effective liaison with professionals and families. And in session 2 of the medication core module presentation or training, we have a case study where we reiterate through this case study all the things that people have learned in the morning session and discuss about what went wrong in that particular case and how this could be rectified. Okay, now this is the site, Spectrum site. We can always supply that to you later on. But let me just go to the site and let's hope it works. Right, can you see the screen? It's Spectrum project.
Yep.
Okay, great. So this is how the homepage looks like, okay? So we start with, we talk about the background, why it's necessary to develop it, like the STOMP issues and over-medication issues and so on and so forth. Then we're going to view our project. Next page is to really how we did develop it, the slide that I have shown about focus group and et cetera, et cetera. Then we show them the project team. Lots of different people are involved. John Rose, for example, is a clinical psychologist. This is a GP. Can you see my cursor there when I move it?
Yeah.
Yeah.
Okay. Tim Weaver is qualitative analyst. Gemma has done a lot of work in this field, and she's my ex-postdoc in Birmingham. Gino O'Hara was the learning disability czar, as we call them, National Clinical Director of Learning Disability. David Branford was the pharmacy lead of NHS STOMP initiative. Then we have Michael Fullerton, is a director in one of the service provider organizations, Achieve Together. It used to be called CMG before. And Vivian Cooper is a mother, and Linda Woodcock is a mother of a person with learning disabilities. Viv Cooper is the CEO of Challenging Behavior Foundation, and Linda is a director at AT Autism. Other stakeholders we had is consultant psychiatrist, speech and language therapist, community learning disability team, pharmacist, then we have service managers from various different organizations. Robin's name is there from Milestones Trust. And then we have trainers from various organizations. These are the service providers organizations who took part, Achieve Together, AT Autism, Avenues Group, Dimensions, MenCap, Milestones, National Autistic Society. We had a steering committee to oversee the project, which was led by a consultant psychiatrist, but it also had a consultant psychologist and a parent. And we had the Learning Disability Advisory Group from Cornwall. And then we have things like the project activity diary, for example. This tells you what happened when, the focus groups, the other various meetings, co-design event, and so on and so forth. Then we have newsletters, and they are in both in accessible format and also in other formats. So here is an example of a newsletter in accessible format. This is the final report to tell people what you have done and what you have achieved, and so on and so forth. Then I will show you this one. This is quite an important one. This is the accessible. If you haven't come across, have many people, and in this one, we just start about definition of psychotropic medication and what this page contains, and then go into the accessible medication. And I'll show you one example of risperidone, which is a commonly used medication for challenging behavior. So this is how the leaflet looks like. So you say it's an antipsychotic and how to actually pronounce the name. And we say you should discuss this with the carer or caregiver. And we say risperidone comes in different formats, quicklet, etc. And we tell them why it's used. It should be used for psychosis, schizophrenia, mania. And then say sometimes it's used for distress behavior, but there's no definitive evidence to say that it works there. And how to take in different forms of the liquid version, etc. What to avoid when you're taking the medication, like drinking alcohol, etc. And then we go into side effects. We tell them not everybody will suffer from the side effect, and not everybody will have all the side effects. So some of them might have some side effect. And the common ones we tell they're about the feeling restless and agitated, feeling stiff, or have shakes in hands and body, and etc. And then we go into more serious side effects, high temperature and stiffness, and what to do if anybody sees that. And then we have other sources to get information from. Have many people seen these or the predecessor of these, or have you used this I mean, this could be used in clinics or in the homes, but also the doctors can print them out and hand over to carers and the person with learning disability. Has anybody seen this before?
No, I've never seen them before, but I could see how they'd be very useful for many of the people.
Yeah, if you haven't seen them, they'll be very
no,
useful.
but I have a great urge to use them now that I know about them. Yeah, definitely. Yeah.
Now the other page, for example, we have this resource page that tells you. So these are the manuals and the slides. We have slides going along with the manuals, because if the trainers want to present directly from the web page the way I'm doing, which is the best option because you can move from one side to another easily. If you don't want to do that or can't do it, then we give them a set of slides to use using a PowerPoint and loads of handouts to go with that. And we have internal and external resources. I've talked about the leaflets just now. I'll show you two other things there. The CATS is a comprehensive assessment of triggers checklist. So this is basically a long list of triggers that you can check out why the behavior is. So for example, we have physical external environment. Within that, we have physical environment, flashing lights, precipitating behavioral problem, seeing certain things, breakdown vans, and so on and so forth. Then social environment, like activities not meaningful to the person, absence of favorite support staff. All this could trigger behavioral problem. Internal environment due to diet, discomfort, new shoes after meals, so on and so forth. Then medical conditions, cardiovascular, allergy, constipation, lots of them. Mental health problem, anxiety, paranoia, depressive disorder, etc. Emotional state, agitation, anger, impulsivity, feeling distressed, expression of volition to get people to leave him or her alone, to get own way, and so on and so forth. characteristic associated with the intellectual disability or ASD, change in support staff not giving clear instructions, and so on and so forth. Communication issue, big thing, difficulty in communicating in general, speech, articulation difficulties, and behavior is a means of communication, as you would all know. So it's a very important issue. Specific activities like exercise, going to chiropody, all these could precipitate behavioral. So it's a long list, but very comprehensive list, and you can give it a try. Yellow page, sorry, not yellow page, yellow book. As I said, it is like a health passport. Your name, GP, I need help with seeing, eating, drinking, my personal information, sensory information, my likes and dislikes, how I communicate emotion, pain, so on and so forth, my medical information, illness, physical health, the medications that I'm taking, antipsychotic, anti-epileptic, health issues, action plans, when they were taken, types of medication I'm taking, and some side effects, possible side effects, just description of them, physical health check, weight, blood pressure, movement problem, fat, blood glucose. These are the checks, health checks into full blood count, etc. But the health action plan templates will give you a very similar template. What you're going to do, so plans next, when to go to see a doctor, and so on and so forth and so on. So if your organization already uses one of these, fine. If not, you can use these. And then we have hyperlinked with various external organizations who have lots of additional resources that you can tap into. For example, this is the Australian National Disability Services site. They have lots of documents on focus on quality of life, communication support, person-centered active support, and so on and so forth. And then this is another European site on autism training. You can check out, and it has different modules. Module 1, Module 3, specific support and intervention program. Module 3, basic principles and strategies for intervention, and so on and so forth. I'm going through this very fast, but this is just to give you a taster of the whole thing. As I say, it's such a huge thing. I can't really cover it all, but just to give you a taster, a glimpse of things, and then you should go to the site yourself and explore it for yourself if you are interested. Now this is I'm going to take you through the actual modules. So as I said before, we have 2 core modules through which we introduce the other modules. So STOMP and the psychotropic medication is the one core module, and the ATM. And within psychotropic core module, as I said, we have other modules like medication review, assessment of behavior, so on and so forth. Under ATM, we have communication needs, and so on and so forth. And the other additional modules like ASD, ADHD, psychiatric disorder, etc., etc. Now I'm going to take you through this core module, psychotropic medication, and then Bharati will take you through ATM. I'll just go through as much of it as I can, and then we'll stop and then hand over to Bharati after another 40 minutes, half an hour. So this is how it looks like. The medication module is divided into session 1 and session 2, and so is the ATM module, which Bharati will present. And in session 1, as I said, we talk about medication, various related issues. And session 2, we talk about case studies, which actually incorporates all the learnings from session 1. So in the beginning, we talk a bit about Spectrum and what it's all about, and so on and so forth. And we just talk about skilled carers, because the idea of this training is to develop skilled carers. So it's sort of define what skilled carers are, and then what other modules are there underneath this module. And then we go into the learning objectives in the beginning from this module. Then, as I said, we start with a case study. In this case, we show a prescription, a typical prescription of an adult with learning disabilities. And this is actually a real life prescription. And it is not uncommon to see this sort of prescription in real life. And then we ask the question, what strikes you in this prescription for an adult who has intellectual disabilities? Write your answers. So maybe I can take 1 or 2 answers from the audience. Would you like to volunteer just to give 1 or 2 answers? And then I show you the model answer. So
what's the question? It's just a variety of medication, and medication covering a whole load of.
Yeah, so it's a cocktail of things, and we don't know why they have been used and whether they're all really necessary. So really, to hammer home the message at the very first slide, very first case study, that there's this whole issue of over medication affecting this population. So then we go into the answer page. What strikes you? The sheer number of medications, 16, including the PRN medication the person is taking. Many of these are psychiatric medication. Many of the psychiatric medications are used to control challenging behavior for which they are not licensed. And many of these are probably not necessary, and so on and so forth. So we have some discussion, and then we go into the answer. Then we talk about what are the different classes of psychiatric medication, psychotropic medication. We have some discussion, and then we tell people about the different classes. What are the side effects? We have some discussion, and we show them the answers. Then we ask how extensive, common you think the psychotropic medication use is, that we give them some statistics. We tell them that it's quite common and used out of license. Why should he be worried about the use of psychiatric medication? We just have some discussion there. Can you think of any situation when it may be necessary? It's not so much necessary, but where they could be used or they're sometimes used. And then, for example, you go to this case study. A 32-year-old man with moderate intellectual disabilities and no speech attends a psychiatric clinic. He has been on multiple psychiatric medications, including a number of antipsychotics at a high dose for several years. He has severe tremor, shakes in the body, and abnormal body movements in facial muscles and arms and legs. And these movement disorders have been present for many years, and is very wobbly on his feet. It was reported that he has a long history of severe challenging behavior. And then we ask the trainees, what do you think is wrong in this particular case? So does anyone want to give an answer?
I think like Alan said, the amount of medication means that actually it would be very difficult to pinpoint what the difficulties are that somebody is experiencing, because there might be lots of sort of effects from medications and the interactions between those.
Yeah, so basically what the simple answer is that this person hasn't probably had a proper review of the medication for a long time. Now, this situation is probably improving now with STOMP initiative and etc., but it probably still happens. And even if there is the review maybe is done by the GPs very quickly, they are very busy people and not experts on this. But what went wrong in another way, why staff didn't think that it is a concern, that is evident in the next portion of the case study. As the staff only got to know this person during the last few years, they assumed that this person always had tremors and that the tremors are part of the learning disabilities. And they did not suspect that these could be the side effect of a medication. So this is what we call diagnostic overshadowing. So a lot of these problems associated with medication and other problems are put to learning disability itself. So this is why this program, the training program is so important, that then the staff could think it through. Otherwise, they think it's just normal. So, okay, so then we have some discussion. What do you need to check during a medication review? So this is the most important bit, and I would like to spend some time on this and take you through the checklist. As I said, we'd like every house to have this. I'll take you to the medication review module. We would like every house to run their own medication review, a STOMP action plan, as some organizations call it. Some organizations are doing it, big organizations, but not all are doing it. So this is how the medication review module looks like, and we have a hyperlink to an international guide that I developed in 2009, and then the recently NICE guideline, local one, and the Royal College of Psychiatrists guideline. And then you have, for example, a hyperlink with VODG's document on preparing to visit a doctor. So that gives you some idea about what sort of things to check before you go to see a doctor. And we'll be covering most of these here. And I don't know whether you've seen the CBF, Challenging Behavior Foundation's documents on medication pathways. They have documents there about challenging the decision on prescribed medications, and it will take you to other pages and so on and so forth. Then we talk about the case study, and then we go to this checklist. This is the checklist that we want the staff team to go through regularly, every 6 months, maybe, if necessary, more often, but more particularly before a formal medical review of the medication. So first question, have you got accurate records of all the medications and their dose? Have you recorded all the recent changes, if any, in medication and their dose? Have you ensured that the person is taking his or her medication regularly? Is the medication working? For example, if used for challenging behavior, is the behavior better, or used for psychiatric disorder, are the symptoms under control? Or if it's epilepsy, are the seizures under control? So that will take, as I said, it's like Wikipedia. You can move from one page to another. So psychiatric disorder module, in there we talk about various psychiatric disorders, and we said that people with learning disabilities can suffer from psychiatric disorders like those who don't have learning disabilities. But it could be difficult to diagnose psychiatric disorder in this population if they cannot communicate their feelings and thoughts, particularly at the severe end, those who have severe and profound learning disabilities. And then we go into different common psychiatric schizophrenia, for example, and then the various manifestations of schizophrenia. You see, it's not uncommon. The staff will say, well, doctor, this person is behaving badly. We're finding it difficult to control his behavior, but his uncle suffered from schizophrenia. So in a way, the staff is assuming that this behavior is due to schizophrenia. Or they will say, this person is talking to himself or going out and talking to the tree in the back garden. So this must be hallucination. So all these myths we explain and counteract through these descriptions. So we just tell them, if somebody talks to a tree outside, it doesn't mean he's schizophrenic. It's part of the, say, autistic spectrum disorder phenotype sometimes. Then you have hyperlinks to go to easy read version of some of these, what is psychosis and what to do and so on and so forth. Okay, so coming back, so we talk about various abnormal perceptions as then we go to depressive disorder, hypomania, bipolar disorder, and so on and so forth. There's an easy read guide to anxiety disorder. So you can move and you can find all these resources depending on who you're talking about. If you're in a person-centered planning, somebody has anxiety, you just check that out. So all the resources are there. And at the end, we just summarize all the main findings. We say adults with intellectual disabilities may suffer from the same psychiatric disorders like others. Psychiatric disorders can be very difficult to diagnose in an adult with intellectual disabilities, particularly if they cannot communicate their thoughts and feelings to others, and so on and so forth. So then we say, has a valid tool been used to assess the severity and frequency of challenging behavior? We usually encourage staff to use some kind of a tool. So we know there's a consistency in reporting. We know what we are talking about when we talk about severe challenging behavior. So there's a simple tool. It's not used so much in learning disability, but it is now used in research, but it's used in general psychiatric population. And this is to measure the frequency and severity of aggression. Fairly straightforward, as you can see, and it measures aggression under 4 main headings: verbal aggression, aggression against property, autoaggression. This is self-injurious behavior in learning disability, and physical aggression. And it's got a Likert scale and gives you a score. So it's always good to use some kind of scale. There are other scales available as well. Then another important thing is the side effect of the medication. Have you actually checked for them? And then you can check the accessible leaflet to see what side effects to expect from the medication that person is on. And other serious side effects like tardive dyskinesia, and neuroleptic malignant syndrome, etc. These are very rare but quite serious side effects, and it's worth knowing about them just in case if you ever come across and you know it's an emergency situation and you have to call a doctor straight away. Then we ask, the staff team should check, is there any worsening of the person's quality of life or any improvement? Again, if you want to have a checklist, we have produced one. There are various quality of life measures, but this is the simplest one, and this is usually completed by a caregiver or a family member. And it's got 2 sections: carer's concern, 8 questions, and quality of life, 8 questions. So in the carer's concern, are they concerned about the person's physical health, mental health, self-harm, aggression, missing work, school, or daycare, risk of accident, their future, and lack of service. In the quality of life, we just check relationship with others within the home and outside home, leisure and recreational opportunities, communication skills within home and outside the home, self-care skills, mobility, access to community facilities. And then we can give it a score, it's a Likert scale. And so we always encourage people to use some kind of a simple score so that you have consistency. And when you go to the doctor, you say, oh, he's better or he's worse. But what does it mean? You really can quantify if you use any of some of these. Has the team produced a hard copy of the accessible version of the medication leaflet, the one that I have shown? You should have a hard copy and discuss this with the person with learning disabilities. Has the support staff consulted the medication information leaflet? Now, these are a different set for the support staff themselves, which is different from this accessible version. Has the team gone through the recommendations from the previous medication review and recorded the outcome of those? Again, this is something in the clinic, we ask the support staff, and we just face a blank. They have no clue what you're talking about. So I think this is an issue of changing people's practice and mindset and culture within the organization, so they are mindful of the effect of medication and over medication, and they take it seriously, and they take it on their own hand. They just don't depend on the doctors to do things. They just don't depend on a psychologist to tell them how to do a behavior plan. They just approach it themselves, of course with the help of professionals, but they take a lot of responsibilities themselves. So it's a culture change that we're after, really. What is the opinion of the person with intellectual disabilities about the use of medication? So this is very important. Has the person been involved? Often the person with intellectual disability about whom we're talking about medication review are not involved. So we need to involve them and their family carers. So person will take you to effective engagement with people with intellectual disabilities. So this is very important. Ways to improve effective engagement, understand the person, their likes and dislikes, and then some activities. For example, this is where the trainees will take part. We ask the trainee, think about one of the people you support and make the following notes about the person. You can complete this activity for as many people as you want to understand how well you know the person. So what activities do they enjoy? What activities do they dislike? How do they communicate with others? Now that will take you to the communication module, which is another very important module about different communication difficulties, speech difficulties, and how to really communicate with them. So for example, we say, avoid double negatives. So don't say, you do not refuse medication, do you? You better say, do you take your medication? And so forth. And different techniques you can use to communicate, like Makaton. There are more sophisticated ones nowadays, E-Tran, talking maps, Vocus, etc. And then there's a link to interactive, intensive interaction. So you have some discussion about that. Now, this is something I'll just show you, tools for talking. This is created by my exposed talk in Birmingham, Gemma. They've got a huge resource and it's a very good, somebody's dog is interested to attend the meeting as well, I can hear. So, so video, there are lots of videos there and the YouTube, you can check out the posters and so on and so forth. But I think Bharati will probably show you one or two of those videos. And then hyperlink with American Speech and Language Hearing Association. And there are 5 standards, the 5 good communication standards produced by the Royal College of Speech and Language Therapists. We have that. And then there's a case study and behavior is a means of communication. And then other useful resources, PBS Academy, Build, CBF, case study. Okay, and then we go into the summary. Be aware of different types of communication needs of people you support. Be aware of the ways to address these communication needs. Prepare a communication passport for the person so everyone is aware of the person's communication need and how to address them, and so on. So, and a communication partner, and so on and so forth. So, and how do you communicate with them? Then the CASD module, this is another very important module. And let me just spend 5 minutes on this. This is very important. So this is autism model, and we start with the definition of autism and different terms used to be used for autism, and then autism symptoms. And then you talk about the persistent deficit in social communication, social interaction, restricted repetitive pattern of behavior and interest, diagnosis of autism in adults with intellectual disabilities and the difficulties associated with that, and the case studies. For example, here we say Johnny has a diagnosis of autism and severe intellectual disabilities. He has no spoken language and he prefers to sit in the corner of the sitting room where he will play with his favorite object, his father's snooker trophy. He will turn it upside down, lick the metal nameplate, and trace his finger along the lettering. He becomes extremely distressed if his toy is removed. And then the Peter's case study is slightly different. Peter has Asperger's syndrome. We don't use the term Asperger's syndrome anymore nowadays. Maybe you could say high functioning autism. He has good verbal ability and attends a mainstream school. He usually manages well in class with support as long as he's able to have his favorite dinosaur figures on his desk. When another child took one of his figures, Peter became very distressed and turned his desk and chair over and began kicking his support worker. So you can see in one sense, these individuals are at opposite ends of the spectrum. However, they experience similar distress when their toys are removed. Then we talk about overlap between ASD and intellectual disability and causes of ASD. Some key facts about ASD: it's a lifelong complex neurodevelopmental disorder which usually manifests itself within the 2nd or 3rd year of life. Males are 4 times more likely to develop ASD than females, so on and so forth. And then we go into this issue of social interaction, very important, and different sort of phenotype, aloof, passive, active but odd. Maybe we don't use these descriptions anymore, it's a bit old-fashioned. Supporting the person to develop socially. These are very important tips there. And then the issue of social communication. We go into the social communication, which is a very important issue. So, so here is an example how people with autism kind of think concretely. And if you ask them a question, they will make a literary interpretation of that. So Kevin's case study says that Kevin is 18 years old and has very good verbal skills. He can recite several of the plays of William Shakespeare. He particularly likes to recite Julius Caesar, and he's word perfect. But when he's asked what the play is actually about, he cannot really say. So you can see it's a literally interpretation rather than abstract interpretation. And that can affect the day-to-day communication with them. So if the support staff says, put the kettle on, Billy thinks, put it on what or where? So he's thinking concretely, literally. Support staff says, pull your socks up. Billy looks down at his socks and is confused when he sees that they're not down. Support staff says, Billy, can you open the window? Billy says yes, but he doesn't move. So Billy made a literal interpretation of the request, thinking he has been asked whether he can or cannot open the window. So the staff will have to say, Billy, will you open the window, please? And then Billy will get up and open the window. So some of these social communication difficulties you have to keep in mind as a staff when you're interacting with a person with ASD. And the sentences, if you use a long sentence, they may be confused. So you can cut it down into pieces. Billy, coat, shoes, park. That might mean Billy put on the coats and shoes. We are going to the park. And then we talk about some ideas about supporting people with the social communication needs. And then the issue of social imagination. And I was talking about talking to an imaginary figure, and that's not uncommon in autism. They have these imaginary friend or figure that they talk to, but they're not symptoms of schizophrenia. It's important to remember. And then we talk about some theories, theory of mind and etc. And then we continue with the how to support these people. Then we go into this very important issue of sensory perceptual impairment. As you know that people with autism and also intellectual disabilities may have impaired interpretation of outside stimuli, which is very difficult to keep in mind if you are interpreting their behavior. So here's a case study. Anita was looking down at the floor whilst her teacher Anita was looking down at the floor whilst her teacher was giving her a verbal instruction. Teacher thought she wasn't paying attention and told her to look at him whilst he was speaking. Anita was unable to complete the task and her teacher told her off. Anita became very agitated and ran out of the classroom. Can you think of the reason why that happened? Can anybody suggest anything?
I might ask you to repeat it, Sumi. My internet's playing up slightly. Do you mind? Is that?
So Anita was looking down at the floor whilst her teacher was giving her a verbal instruction. Teacher thought she wasn't paying attention and told her to look at him whilst he was speaking. Anita was unable to complete the task and her teacher told her off. Anita became very agitated and ran out of the classroom.
Mm-hmm.
Any idea why?
Well, the first thing that springs to mind is maybe her inability to look at someone directly face on for the anxiety that might be created due to her autism.
Okay, so that's one thing, that the eye-to-eye contact, which could be very stressful to people with autism. And in this scenario, Anita was not able to process information through her auditory and visual channels at the same time. So this is the issue of using different sensory modalities at the same time. Because she had to look at the teacher, she was unable to process the verbal instruction. So something worth keeping in mind. Now, then we go into this whole issue of sensory abnormal interpretation of sensory stimuli. And we put them under various headings. So for the visual system, for example, if somebody is hypersensitive, they may have distorted vision, may find bright lights painful. If they're hyposensitive, they may use peripheral vision as central vision is blurred. And how to help somebody with hypersensitivity, use diffuse soft lighting. How to help somebody who has hyposensitivity to visual stimuli, use flickering lights or toys that stimulate the visual sensory system. Similarly, with hearing or auditory system, this is the most common one. If they're hypersensitive, the noise will appear loud, sounds can be distorted. If they're hyposensitive, they only hear in one ear. So how to help with the hypersensitivity? Use earplugs, iPad with familiar favorite music. How to help with the hypersensitivity? Play music, keep the radio on in the background, sing together, so on and so forth. And then we go into touch sensitivity, tactile sensation, taste, gustatory, and then the smell, and then the balance, vestibular system, and then the body perception, body awareness, and so on and so forth. And then we discuss about other strategies to help them with this sensory problem, creating a low arousal environment, and so on and so forth. And then we go into the summary. Okay. So going back to this model on effectively engaging people with learning disabilities, we have an activity for the trainees. We then show them this one-page profile and then ask them to just put their own profiles about the support staff, people important to me, what I enjoy talking about, hobbies I enjoy, places I like to visit, how to support me, what is important to me. And then we create the same thing for a person with learning disabilities who is supported by the support staff. And then if possible, the team might decide to kind of match as closely possible a support staff's interests, etc., with a person with learning disability to be their key care worker. Things to do and things I would like to, is this what is there? Oh, I see. This is a poster from Talking Tools that GMI has produced from Birmingham. And their website is very useful. Tools for talking resources, yeah. And then developing skills, very important. That the staff should concentrate on developing the skills of the person rather than their behaviors. So active support, basically. So communication needs, we have talked about how to actively engage them, and the balance between taking the risk when they develop skills, for example, traveling on their own, going to the corner shop and so on and so forth, and taking the risk versus developing the skill, how to do it gradually, what sort of support needed. So we really need to think it through very carefully. You can create visual timetable for them, very, very important because they may not understand the verbal timetable. So create a picture timetable for them for their day-to-day activities. Otherwise, they might get confused. You say something in the morning and somebody else comes and says something in the afternoon and they get very confused and disturbed and then may throw a tantrum. And you don't have a clue why that is happening. Then going back to this medication checklist that we originally started with, then we talk about alternatives to medication. Has the doctor considered alternatives to medication? Are they talking about withdrawing medication? If not, why not? And if they're talking about considering withdrawing, what is the plan and so on and so forth. Then we have a list of things, information that needs to be taken to the clinic for medication review. It's the same list, kind of what you have discussed in the in-house staff-led STOMP action plan medication review. The main themes from there, the information that you take to the clinic. So it's a bit of a reiteration of the same list. Then you have this item on what questions to ask the doctors. Can people volunteer to give some suggestions that when support staff or go to the clinic for a formal review of medication by the doctors, what sort of questions they should be asking or should prepare to ask?
This is the support staff asking
Support
questions
staff,
to the,
accompanying support staff. Now, this is why we need to do this review, so that this is discussed in the staff team. Support staff goes on her or his own with the person with learning disabilities, but they have discussed in the staff team STOMP action plan or medication review what sort of questions to ask the doctor. So although he or she goes alone on her own, but he takes a question from this staff meeting.
Maybe having a clear, establish a clear understanding of what each medication is for. That might be a starting point.
Yeah. So standard questions.
Even maybe to ask for how long that particular service user has been on particular medication.
Yeah. And how long they should be on it? How long are they on it, and how long? So some of the questions, for example, is the medication making a positive difference? Why was the medication initially prescribed? For challenging behavior or psychiatric disorder? Are there any other non-pharmacological management options available? What are the side effects I should look out for? What action should I take if I see any side effect? What are the monitoring requirements of this medication, such as blood tests? What if the person finds it difficult to swallow the medication? Have there been any change in the person's physical or mental health? Is the medication still needed? What is the plan for eventual reduction or withdrawal of medication? So lots of emphasis on withdrawal. We are giving the sort of onus back onto the staff, because doctors are blaming the staff, saying, well, you come to us and asking for a magic bullet, we prescribe. So staff are now asking the question, if they have this training, well, why are you prescribing? Please explain. It's not challenging, but it's a discussion. So they feel empowered, and they keep asking, are there alternatives? Could the medicine be withdrawn? Of course, there's a lot of worry about withdrawing medication and around it, and a lot of risks associated. And so we have a full module on the withdrawal of medication to really put staff's mind and family carers' mind at rest. But that's an important issue. So the whole idea, as I keep saying, is really to empower support staff, give them the knowledge to ask right questions, and so on and so forth. Stop medication checklists, side effects, assessment of behavior we have talked about. And then there's this sort of flow chart. If the doctor is starting the medication, they should really do a full assessment of the behavior with the help of the support staff team, and formulate a working hypothesis. Why are they using medication if they're using it, and how long they'll be using it for, and what will they be looking for as an outcome, and what will they consider in terms of withdrawing. So monitoring of treatment, getting feedback from various individuals, including the person with learning disabilities themselves, evaluation of their quality of life, and etc., and consider withdrawal. So you have a flow chart, which is mainly for the doctors, but then the staff would be familiar with this flow chart, then they can discuss this with the doctors and feel empowered. And the monitoring sheet are antipsychotic, height, weight, liver function test, etc., etc. And then at the end, for example, we have so this is the assessment. One is this, I haven't had time to go into it. And any other assessment like CATS, key support worker should conduct the assessment in consultation with others. So this support staff can do their own assessment of behavior. They don't have to wait for the clinical psychologist to come and help them with it. They can do it themselves. Collaboration with the key individuals, like stakeholders, key person, and the family and the professional, shared information with the key family members. Family members can give you a lot of ideas. Family member to inform any change in personal circumstances. So you've got a full module on family members and how to interact with them and liaise with them effectively. Then the whole issue of monitoring side effects and etc. And then the capacity issue. And then if they don't have the capacity, the best interest session and so on and so forth. So we just moved from this original core module on medication, where we're talking about how to do the medication review and the checklist and so on and so forth. And then we talked about what questions to ask the doctors in the clinic. And and then we talk about withdrawing medication. I'll just try this one and see whether it helps. This is a person with learning disability whose medication was withdrawn and quite successfully. Let me see if you can hear it. If you can't hear it, can people hear this?
No, I can't hear it.
No, no, I can't hear it.
Okay.
No.
Okay. No, I'll leave it then. Okay. Anyway, that's a very good video from a person with learning disability himself. Then what you do, we just summarize all the points you have discussed in the morning session. Know what to do, what should be involved in the medication review, and so on and so forth. We have discussed. Then we in the session 2, and then we give them some homework to actually look into other modules. Then in session 2, we start with the case vignettes, and on the back of that, we actually reiterate all the issues that we have discussed during the morning session. So I'll very quickly go through them and then hand over to Bharati. So this case vignette says, Larissa has profound intellectual disabilities and receives many medications, including a number of antipsychotics, which she has been receiving for many years for her challenging behavior. One day, when Larissa's behavior started to deteriorate, the support staff spoke with an on-call doctor who advised on the phone to increase her dose of haloperidol. However, her behavior worsened and she continued to hit her head against objects. This led to Larissa being physically restrained. Any idea why her behavior may have deteriorated?
She may have been suffering from a side effect from that medication anyway.
Yeah, so if you look into the answer, the increase in the dose of haloperidol has caused side effects in the form of headache and agitation, which is manifested as head banging. This demonstrates how side effects of psychiatric medication can make behavior worse and lead to restrictive practices. Then we continue with Larissa's story. And within a week, Larissa was taken to a psychiatric clinic for her medication review. However, a casual temporary support staff who does not know her well attended with Larissa in the clinic. The temporary support staff only knew that Larissa's behavior has worsened, but did not know the name and the dose of medications Larissa was taking. The psychiatrist spoke only with the support staff during the whole appointment. As the psychiatrist did not have much information, he decided to increase the dose of haloperidol. The temporary support staff was not able to contribute much to the decision-making process and did not ask psychiatrists any questions. What do you think went wrong there?
So the people supporting her to the appointment needed to know her very well and have helped her to plan for the appointment. So thinking about what some of the issues were and have the right kind of questions to ask.
Also to have had like the history of the medication or even the medication, medication drugs, to see what she's actually taking and generally to have the history on how long she has been on medication rather than to rely on 100% on support staff.
So the doctor didn't know that the haloperidol was increased recently and that did make things worse than better. So lots of things went wrong, and we discussed that under various headings like assessment of behavior, that this wasn't done properly by the staff team and it wasn't recorded. The information was not taken to the clinic. Effective collaboration. It doesn't look like that either the person with learning disabilities or their families were involved in the discussion. Family might have given them some clue about this may have happened before, and they could have probably told them that if you increase the medication, then it might make things worse. Haloperidol is an old generation drug. It shouldn't have been really used, and it could have been, if it's necessary to use a drug, then a newer generation antipsychotic could have been used. So monitoring the side effect of this drug wasn't done properly, and the full medication review didn't take place. Okay, I've gone, I think, so yeah, the idea is to look into this triangle: person, family, professionals, and support staff sort of interaction, the dynamics among these three groups of people. I have gone over kind of 2 minutes over than what I promised Bharati that I'll do. So I'll stop and hand over to Bharati, and she will take you to the ATM module. And if possible, I could probably leave 10 minutes at the end. I know it's Friday afternoon, sun is out, people are very keen to leave this meeting as soon as possible, but if possible to have some discussion. So over to you, Bharati. I'll
Thank
have
you.
to just, let me see if I have I stopped sharing?
You
I stopped
have.
sharing? Yeah, okay.
Let me just share my screen. Right, so everyone can see my
yeah.
screen. Yes, correct. Thank you. So yes, as Shumi mentioned, I will be going through the alternative to medication core module, and he's just gone through the medication core module. They're both part of the face-to-face training, and usually either one of them, it takes a whole day to go through one of them really, but we will be covering just the important areas that the alternative to medication or the medication core module covers. The purpose of alternative to medication core module is to help support staff really understand the person and the person behind the behaviors and also causes of challenging behaviors, because we know that all behaviors have a meaning and a function and are often communicative. Therefore, if we are able to understand the person behind the behavior as well as causes of behaviors are identified, we can develop effective intervention plans or support plans to reduce challenging behavior effectively without needing to rely on medications for challenging behavior. So that is what's covered in our alternative to medication core module. And we also have other modules that are introduced in our training. So these two core modules, which Shumi has shown via his checklist. And again, as Shumi mentioned, there is a PowerPoint, but if you will be using like Zoom or Teams to like deliver the training, I would suggest this website version, because you can then effectively move from one area, one basically module to another quite quickly and quite effectively as well. So this is our alternative to medication core module, and it looks very similar to medication core module. It starts with the ultimate aim, our aim of the project really, and then goes on to describe what skilled carers are. And we hope to develop skilled carers at the end of the training program. Afterwards, we then go into the learning objectives of the core modules or the training. So the alternative to training, some of the learning objectives are to understand why some people with intellectual disabilities show challenging behavior, how your feelings and responses to the behavior and attitude towards the person can affect the behaviors, and so on. So you can have a look later on. And again, it starts with the case study. So I'm going to read you this case study. So imagine you have just arrived at work very late as you were stuck in a traffic jam and your little boy is unwell at home. The moment you arrive, Simran, one of the people you support, starts to shout at you and throw things at you, injuring you. And then once we've discussed the case, I've said the case study, we then go into discussion. So we'll ask you question and answers just to have a discussion around the case study. And now I know, I think in the audience, we don't have a lot of support staff, and there's a range of professionals in the audience, but please imagine yourself as the support staff who is supporting Simran on that day. And, you're very late to work, you were stuck in a traffic jam, your boy at home is very ill. And as soon as you enter, you're kind of presented with this challenging behavior. So I would like to ask, what would be your sort of immediate reaction or feelings to Simran's behavior? So just sort of your knee-jerk reaction. Please feel free to like unmute yourself and like answer the question. So how would you normally like immediately react to this situation? And again, there's no right or wrong answer, because these are your feelings and obviously they're all valid. So how would you normally feel if you were sort of gone to work and then you're just presented with challenging behavior?
Possibly you yourself might feel quite irritable and not quite understand why Simran, not be quite as tolerant as Simran as you might normally be.
Yeah, that's true as well, because obviously you've got that stress going on, so you're already irritated, frustrated. So when you go there, you might be more stressed and more frustrated. So you might feel a bit angry, maybe upset, and a little like irritated. Anybody else?
I think there might be a bit of resentment as well. You've rushed into work, you know, you've left your little boy at home, and the person you've rushed in to support is throwing things at you.
Exactly, yeah. So we did have similar sort of responses in our training as well. So it went from all the way from confusion to frustration. Confusion because you don't know what's really going on, and frustration and anger and a bit irritated because you've got a lot going on your plate, and this sort of situation would sort of make you feel a bit irritated and frustrated. So if we look at the model answer, again, all of the answers are correct. It's just this is like sort of the model answer we have developed. So it is understandable that you may feel upset, stressed, angry, and maybe even scared. You're already worried about your son and about being late, and this incident will further frustrate you. So that would be sort of everyone's initial immediate reaction and feelings to this. Then we talk about how are you likely going to respond to Simran's behavior. So how would you respond to it, keeping in mind that, you know, you're a bit irritated, you're frustrated, you've come in late, you have an ill boy at home, and you're just really worried about your son as well. So how are you likely to respond to Simran's behavior when you're feeling this way?
I should imagine one of the risks is how you present physically with your body language, for example. And that's something that you're not necessarily in control of all the time unless you have an awareness of how you might be coming across. So you might, I don't know, just maybe shoot a stare, for example. You might try and sort of stand your ground and be a bit sort of show your annoyance in your in your body language, maybe.
Yeah, and I think someone wanted to say something.
Yeah. Well, I suppose in the situation, first of all, you if you work with that particular individual, you would have known that maybe things which make them agitated, things that, you know, different situation which make them, you know, goes off baseline. So I think if I was in the situation, I work with individuals challenging behavior and a specialized unit. So I kind of know all our, each of our 5 service users. So if I know that I'm gonna be late and I know that that is one thing which will agitate them, let's say if I phoned the unit and say, oh, can someone be there for me? I would ask them to make it clear that that other person is only going to be there for particular time. So even when I arrive, she will they will understand the changes that, oh, this is what is going to happen. Of course, as you said, yes, I will be, you know, frustrated and because of the reaction I get, but I think my reaction will be to step back and show them that I am apologetic and I'm there for them when they need me until when they come down.
Yeah, so we do have a sort of a range of responses as well. So some are a bit positive, you know, where you can step back and then kind of consider your response, and, you know, you may be apologetic as well. And then again, you can have, you know, react in a manner that might be a little inappropriate, or, you know, because you have so much frustration in you and you're stressed already. So, you know, you could respond without meaning to respond in that way. So the sort of model answer we have is that since Simran started shouting at you as soon as you arrived, this incident would appear to be unprovoked. So we don't really have a lot of context, so we don't know what's kind of provoking the challenging behavior. You may believe there are no triggers for the challenging behavior. You may blame Simran and believe she deliberately attacked you. You may think she's an aggressive, unreasonable person. You may think she doesn't like you. You may try to help Simran calm down. You may react angrily. You may ask for help from your colleagues, like I think MG just was saying that you could ask your colleagues to help you as well. So I'm going to quickly differentiate feelings and reaction and responses. So the feelings and reactions that we initially feel to a situation are often emotional and psychological. So they are unconscious and we have no control over how we feel about a situation. So it's quite difficult to change the way we initially feel or react to a situation, including challenging behavior. And it is driven by one's beliefs and biases. Where and some examples include, I feel scared, I feel angry, I feel vulnerable. Whereas responses are behavioral physical response to a situation, and it is a conscious decision, and it is driven by thoughts and consequences. So some examples include saying, what are you doing, in a confrontational manner, taking a step back, as MG just said, and considering your options as well. That is also a response because you have chosen not to do something and take a step back to kind of think about your options. Shouting, arguing back, getting help, all of these are responses, examples of responses. Then we look at what factors can potentially contribute to the way you felt and responded to Simran's behavior. So if we felt frustrated or irritated, the number one factor that caused that feeling and response is because we do not have effective stress management skills. So because we're so stressed, we have a boy at home who is very ill, we're very late, and all of these will kind of build upon each other and kind of explode, and you would respond in a manner that's a bit negative or inappropriate. And if you're confused, you don't know what's going on, and that's true because we don't really have a lot of context. If we're feeling confused and we respond in a way that's like, we're trying to help Simran because we don't know what's happening. We try look in the environment to see what we can perhaps adjust to help meet her needs. The factor that contributes to that is our inability to understand Simran and understand why the behavior has actually happened. So if you look back in our case study, there's not a lot of context. We don't know what's wrong with Simran. We don't know what has happened. We just know that her needs are not being met. So we don't understand her challenging behavior, and we don't understand her. And that's why we feel a bit confused and may kind of respond to try to help her calm down. Those are sort of the factors that contribute to our feelings and responses. And then we ask our trainees, how could you improve your feelings and reaction and responses to Simran? And considering the two main factors we've just discussed, the way you could improve your feelings and reactions and responses to Simran's behavior is by understanding Simran, understanding the causes of challenging behavior, and being able to manage our stress effectively. And that's what's covered in our alternative to medication core modules. We have 2 sessions. Session 1 covers understanding the person, building a rapport and understanding challenging behaviors through assessments, and session 2 covers stress management, which we can briefly have a look at. So after that, we go into understanding the behavior. So here is the full story of Simran. Simran has moderate intellectual disabilities and requires regular help for many of her needs. She's unable to speak but uses a communication aid, 2-word combination and gestures. It was a very hot day and Simran was sweating a lot. Simran has fallen asleep in the afternoon due to the heat and has woken up feeling very tired and hot. She wanted a cold drink and wanted to turn on the air conditioning in her room. She did not want to bother the support staff, but she could not work out how to use the remote control for the air conditioner. As a result, she felt frustrated as she was unable to call someone for help and upset because she was unable to communicate her needs clearly. She wondered why the support staff didn't turn the air conditioner on. As she was unable to speak and support staff were not in her room, she began to shout. As soon as you entered her room, Simran started throwing things at you, which injured you. So now we have the full story. We immediately know what's wrong with Simran and how we can help her. So let's quickly discuss, what do you understand as the reason for Simran's behavior? So I'm just going to show you this story. So what do you think were the reasons for her behavior?
She was unable to get the support she wanted at the time she wanted it.
Yeah.
So when a member of staff came in, that all came out then.
Yes, exactly. That's exactly it. So there's so many triggers in this obviously case study, the hot day, you know, not wanting a cold drink and not being able to turn on the air conditioner. But the main sort of reason is because she was unable to like express her needs through speech. So in this case, it is difficulty of Simran expressing her needs through speech and therefore expressed her frustration through anger. So when she needed support, it wasn't there basically. And when Simran's support staff came in, it sort of just came out. So remember, behavior is a strong means of communication, and Simran's behavior is communicating something to the support staff. So now that we know the whole story, how would you now respond to Simran? Because obviously we know how we can effectively help Simran. So how would you sort of respond to Simran now?
Help her put her air conditioning on, get her a drink.
Yeah, so it'll be a bit more positive because we know exactly the exact causes of challenging behavior and how we can actually support her to meet her needs. So our responses would more likely to be positive and helpful, and that will help her reduce instances of challenging behavior as well. So I'm going to go through some the cycles we have developed. So this is a negative cycle where our behaviors, the way we think and feel, will contribute to challenging behavior. So when we don't know the causes of behavior because we don't know what has happened and we're not able to understand, like for example Simran, and we have so much stress and we can't manage our own stress, the challenging behavior is often perceived as negatively. It's perceived negatively. We have frustration, we have anger, and that may lead to a negative attitude and negative responses, such as staff saying in a confrontational harsh tone, "Don't shout at me." However, our responses will then further act as a trigger, causing this vicious cycle, and the cycle doesn't break. However, when we know the cause of challenging behavior, for example, from that case study, we knew exactly how to support Simran, and we're able to understand Simran, and we can also effectively manage our own stress, the challenging behavior is perceived positively, and we will then develop positive attitude, and our responses will also be positive and helpful, which will reduce instances of challenging behavior and breaking the cycle. So obviously we'll try to help Simran turn on the air conditioner, give her a cold drink, and maybe even teach her how to sort of ask help from support staff as well, just to sort of encourage her independence and promote her independence. So we've discussed before that initial feelings are very difficult to change because they are so unconscious. Because so if a behavior is presented, although we may struggle to change our initial feelings, we can change the way we respond to it through knowledge and understanding. So we need to create some space to reflect and appraise the situation, which is what we can do in the appraisal section, and then we can bring in our own knowledge and understanding of the person, circumstances, and causes of behavior, as well as our own stress. And this will help us react appropriately and positively as well. And that will sort of break the challenging behavior cycle as well. So I know Robin has a very similar experience in his team. I think he recently supported a team who has gone through similar experience to Simran's case study. Robin, would you like to share your experience, and then I can finish off with the video?
Yeah, absolutely. Yeah, thank you. It's just so interesting. So as a service manager, I'm regulated by CQC to manage 3 residential care homes within Milestones Trust, and this really speaks volumes to me. Recently, I was supporting. I was in one of the services, and a member of staff asked if they could have a chat with me. That's usually not a good sign to begin with. So we went off for our chat, and the crux of the chat was that the member of staff was struggling with the behaviours displayed by a certain service user. In essence, saying the way that she speaks to other service users, other staff, there needs to be something done about it. Now, I thought that was a very interesting way that the member of staff sort of delivered. You know, there must be something done about it. And I said, okay, well, have you considered, first off, have you considered, as a PBS trainer, this comes naturally to me, but have you considered her previous trauma, for example? Have you considered, the restrictions that have been placed upon this individual? She didn't choose to live here. didn't choose to live with the people that she lives with. Have you considered her dual diagnosis? To which the member of staff said, well, it's just not fair, something needs to be done about it. Interestingly, the very next day, I received a phone call from the very same member of staff asking me to go home. I said, okay, well, why do you need to go home? She said, well, my partner is struggling with his mental health and I would like to support him. I said, oh, isn't that interesting? I had to become very professional straight away, obviously. But what was really interesting for me is that why is it that staff find it much easier to forgive people in their families, in their friendship networks, for having blips, having complex behaviors, but are at times less able to sort of, you know, weather the people that they support? It was really interesting, and it wasn't a conversation I wanted to get into there and then because the individual was clearly quite distressed. Yeah, for me, it's she also mentioned that she felt that the individual had dementia. I said, okay, well, how are you drawing on that conclusion? He said, well, it's not really so much that as I think there's probably medication this person can take. Wow, okay, so you've completely ignored all the alternatives to medication that we've done. You completely ignore the fact that, you know, via many multidisciplinary team meetings, we've actually awarded this individual with extra one-to-one time. There was so much that has gone into helping this person cope with their feelings and their behaviors and the way they display themselves. And it was there we go, exactly that. Absolutely. What I got from this conversation was the member of staff was attributing the theory that this service user should be more in control of her behaviors, if you like, and was quite happy to diagnose dementia in an attempt to get medication involved. And it was very interesting how quickly staff can go to medication. Unpicking that culture, if you like, is you know, because it's embedded, I believe, you know.
Yeah,
So it's why
you hit the nail on the head, really. And although lots of improvement had taken place over the years with some change, but there's a lot to be done. And this is why the whole emphasis of Spectrum really is to change the attitude. Okay, Bharati, you don't have much time left, so quickly go through whatever you have left. Yeah, that's very interesting, but it really supports all the sort of notion of what you're trying to say in Spectrum. Yeah, it's still alive, the sort of issues that we are addressing. Yeah.
Yeah, so I'm going to read you some quotes, and I think it sort of mirrors what Robin has just said, because obviously when people are under a lot of stress, they don't realize, you know, the responses that they're doing is a bit inappropriate, and they sort of focus on medication straight away. Maybe we should use medication to manage challenging behavior, which is often inappropriate. So these are some of the quotes we extracted from our focus group, and we thought was really important to share with support team. So remember, people may behave differently in different situation and environment and in the presence of different people as well. I mean, this is the case for us. We behave differently when we're at work, when we're at home, when we're with our spouses, friends, parents, children. So this would be the case for people who have disabilities as well. And support staff may be scared of the person, but keep in mind that the person themselves could be scared as they move into a new environment, particularly if they're moving out of institution after many years. Facing community living could be very scary for the person. Similarly, having to get to know a new team environment is challenging, and often thrashing out may be a defensive response on their part. Remember, sometimes you may not be able to change the behavior. So rather than fighting against it, work with it to adapt and minimize the risk. Top tips we have for in this spectrum is offer maximum consistency of approach, help the person to understand what is expected of them by having clear, predictable routines, introduce any changes gradually, help to explain changes by giving visual cues. If the person becomes agitated, understand that sometimes the usual strategies for calming may have had the opposite effect and wind them up even more. So if the person has a special interest, do not try to stop it. If it causes concern, you may be able to limit it. In the meantime, be positive. And again, understanding the person is very crucial to as person-centered support plans. And we in this module, we sort of give them tips to kind of build rapport and relationship with the support with the people that they support.
Bharati, did you just gonna go up? You're just showing that. Was that the video you're going to show?
No, it's not this. I want
My journey to independence.
Would you like me to show this? Because I wanted to show the what makes a good support staff video as well.
Okay. This one maybe just 2 minutes. If people could hear the sound. I don't know whether you can hear the sound.
I think it will work because I'm not using the headphones. Let me just see.
Oh, maybe that's why.
Yeah, because of the headphones. Yeah. Let's just see. My internet is a bit slow. Can everyone hear it?
Yeah, you can hear it now.
Yeah, I can hear.
But it has stopped.
Yeah, it's not.
I used to live with my mum. I moved into my group home a year ago. I was nervous at first. It was difficult moving home, but the staff have helped me to settle in. They helped me learn how to cook and help me plan my meals. I like to cook Indian food. Some things I can do for myself, like cleaning my room and ordering a taxi. The staff support me to go out. They support me to go to the temple. Now I am learning how to go to town on my own. I'm learning to be more independent.
Okay, Bharati, you can stop now and move
here.
to another thing.
I like living with other people. I would not want to live on my own. This
just to
is
give a glimpse of what you have in the video. Yeah.
Yeah. So
I also live here.
This was developed by Gemma as well, and it's just part of people with disabilities journey to independence. I want to quickly show you I wanted to quickly go through this as well. I think this is very important on how support staff can effectively develop persons' independence. So this was also extracted from the focus group. A person who has moderate intellectual disabilities moved to a community house with 3 other residents from an institutional care where he lived for many years. Staff were told that he regularly displays challenging behavior. However, after 1 year, this person was going out to the community regularly, made friends, and showed no challenging behavior. The support staff said that as a team, they concentrate on the person and not his behavior. They developed a rapport with him and concentrated on him to gradually develop his skill in small steps. It is important to make the right balance between the need for supporting the person's independence to foster a in a task by providing timely and appropriate support. So it's really important to improve someone's independence because you will help them go to the community regularly, and when their quality of life is improved, oftentimes challenging behavior is also reduced. So I will end with the video that I want to show you about what makes.
There's a top tips at the bottom.
There's this top tips. This is regarding relationships as well. So results and progress can be slow. Do not give up. It often takes a long time to form a relationship, and every person is different. So what works for one may not work for another. Every person is also variable. If they have had a bad day, don't feel like it's your fault. And if all fails, leave alone. Tomorrow is another day and a new start. So you can always try again. So it's not the end, basically. So I'll quickly show you the video for what makes a good support worker, and then we can maybe end it and then take some question and answers.
Maybe after this quickly, the session 2, very quickly, what is there?
Okay.
But maybe this video for a couple of minutes.
A support worker is someone who helps you to do things. She might help you to learn something like cooking for yourself. He might help you to plan something like what bus or train to catch. She might help you to solve a problem, like how to put the numbers in your new phone. I think that the most important thing about my support worker is that he is good at his job. He knows my support plan and he knows what I can do on my own and what I need help with. She encourages me. He is also like a friend. He understands me and he understands my moods and feelings. He is a good listener. And she talks to me too. I know her and she knows me.
Okay, Bharati, you can move to a very quick glimpse of session 2.
Yeah. So we actually have the resource linked for tools for talking. So you actually have a resource that shows, it's like a resource pack where the question asks what makes a good support worker, and you can actually fill that up with the people that you support, so you know what sort of things support staff has to improve to build a relationship and become a good worker for the people that you're supporting. So session 2 covers stress. So what we normally do is go through factors that at work that are likely to affect support workers. Then we have some quick list on how service managers can help support staff to kind of maybe reduce stress levels and even provide autonomy and encourage, provide empowerment to support staff by recognizing their value, autonomy, providing increase in skills as well, and some of the manager traits that might be helpful, which can help reduce stress levels in staff, but also promote empowerment of support staff, and how organizations can help as well. Then we go into some examples of how support staff can support each other, and then factors within support staff that are likely to affect your stress. We've also got, and how we can address that. And we've also got a tool, basically it's a wellness, it's called the Wellness Recovery Action Plan. It was developed by Coupland. And support staff can fill this in their own time to see what sort of factors affect their stress, and how what people around the support staff can do to sort of reduce that stress level, including managers and other support staff there. Then we've also got a stressful experience task, which basically shows how you behave differently when you're in different emotional states. So for example, when you were frustrated, you would respond differently, and when you were confused, you would help try to help Simran calm down. So this looks at how your emotions can affect that as well. And then we have some stress management resources from the NHS. We've just linked some resources for anxiety, you know, if you're going through bereavement and so on. And we've also got stress management. I can't remember what we hyperlinked. So how to manage your own stress, and it's by Mind, so it's their resources. So we've got lots of external resources as well on how to manage your stress. And then we end with a 5-minute sort of meditation to help really calm down and sort of end the session, alternative to medication session. And then take home messages, self-reflect on your own reaction and response to the behavior, get to know what triggers stress in you, and learn how to manage your own stress. And then we've got homework, which encourages support staff to really go visit our website and look at the resources and modules we have developed. So that is the alternative to medication. Should we?
Okay, yeah, thank you, Bharati. We have got only 7 minutes left. I know people are very keen to go Friday afternoon. Very quickly, I just wanted to hear from people, just kind of overall impression, but also the overlap with the current training programs that you have in various organizations, and how it can complement and where is overlap. Those who are maybe PBS practitioners can give some feedback.
I mean, it's interesting how you can see the concepts of PBS in this, but it's there isn't a lot of mention of medication in positive behavior support theory training, and I think it would be so beneficial to teams to actually have the confidence, and again, not necessarily use the word challenge, but actually ask the GP, for example, for explanations into why this person is on this medication, but also to be armed with charts, for example, research, an idea as to whether or not someone's inability to learn a skill is because of the medication that they're taking, for example. That's something which might not necessarily be discussed in positive behavior support. So, yeah.
What are the areas usually covered in positive behavior support training for support staff themselves?
So, well, I mean, it's a combination, isn't it, of sort of, proactive measures to ensure that, we're sort of identifying triggers and removing triggers. Also understanding, the essence in my interpretation is understanding behavior as communication, and often, presenting itself in where there is an unmet need. And the risk is that then staff can attribute the theory that service users should be more in control of their behaviors, and therefore it's something personal, because there are risk factors associated with challenging behavior emerging. And it's quite you have to be quite delicate in the way you deliver it, but essentially there is a possibility that the way staff are presenting themselves to service users is in itself a risk factor, for many different reasons. How you present yourself physically as well is huge, absolutely massive. So for me as a service manager and a positive behavior support trainer, it's very interesting when teams are going through discourse and you're working with lots of agency and unfamiliar staff. The staff that are the most likely to lead a shift because they know the service, they're the ones that are having to work more often with the person that's displaying the complex behaviors. So they suffer burnout, and that in itself can be very unhelpful.
Can you hear from other people the kind of sharp end, like the staff, support staff themselves? We have a couple of student nurses, I believe, but any? I think in a way we thought these sort of programs could be useful for support staff starting at the very beginning rather than more mature staff. Then you have the time to kind of mold them. So, sorry, somebody was going to say something. Sorry, carry on.
Yeah, that was me. Yeah, it's true. I'm a support staff, and yes, like what Robin said, I missed some of the points because of my internet, but it's really true. So we do PBS training, but it's really difficult when you get a lot of agency staff in the unit, and you are the only one, the service user. It's really difficult. At the end of the day, you just you're burnt out, and it's really difficult to deal with everything, and that's where the stress and everything comes up. So it's really difficult.
Absolutely. Yeah, absolutely. Yeah, but I think when you go on, sorry, when you scratch the surface.
Carry on. Carry on, Rob.
When you're delivering theory training, and I just see your name as MG, but you're absolutely right. You create a space where you give permission to staff to talk about those feelings. And I think that's a really important thing to also explore with staff. So staff have an opportunity, a permission to feel the way they do sometimes. I think that's really important that you create that safe place.
That's what we have in our program in session 2 of the ATM. Is how to support staff themselves and their own stress, which is a major chunk of it all. As you said, there's somebody's own problem at home and so on and so forth. I was just going to leave the website and our own email address for you to take home if you want to. Can you see the screen?
Yeah.
Okay, I'll just leave this last. Oops, sorry. last slide, yeah, for the link to the Spectrum modules, and also our own email address if anybody has any question. Okay, it's almost 4 o'clock. Alan, you're chairing the meeting, and yeah, so
Yeah,
it's up to yeah you. Yeah,
a couple of people have already left, so it's probably an opportune time to sort of wrap it up. I will be sort of putting the recording on our Facebook page and probably our YouTube channel as well, which is quite new. But would you be up for fielding any further queries by email, Shumi? You know, because I can see all sorts of ways we could, you know, use the material that you've presented. Not least, you know, some of the formats that you've gone through, which are around, you know, assessing what the triggers are, other sorts of things like that, you know, more for the sort of PBS planning side of things.
Yeah,
so,
yeah.
You know,
I think you can use them and see how effective they are and how useful you think they are. Yeah, I think you have the site itself. You can post it there. Our next step is we are looking for some funding to do some feasibility, just to see how it is actually, how it could be implemented in practice. So we are looking into 12 group homes where we'll be introducing it. So if anybody is interested to take part, you can contact me. We won't know before next year whether we have the funding, but if we do have the funding, we'll kind of implement it in a bigger way in a smaller group, about 12 group homes maybe, and we'll train the service managers in each group home, and then we'll expect them to roll it out among their own staff team, and then get some feedback about how it went. The whole idea is to really, as I said, to embed it in their day-to-day practice, a bit like PBS, but you have the medication bit, which is an extra physical disorder I didn't have time to go through, lots of extra things. So really for them to use this as a reference point. So that will be the real test for its success. So that will be next year. But yeah, if anybody's interested, you can contact me or Bharati, and we'll keep your name in the list. And thank you very much for inviting us. Yeah.
I show that Milestones, another local, you know, organization, would, you know, be very happy to support you in that project. Should we? Yeah.
Yes, of course. I mean, we have the link with Milestones via Robin, and there was someone else, I've forgotten, Robin, who initially introduced you to me. I contacted him.
Ruben Collins,
yeah?
our clinical nurse lead.
Yeah. So if there will be possibility of involving Milestones in that study, you can pick up maybe 1 or 2 homes from your organization. And if there are other organizations locally, I mean, I don't know whether anybody else from any other organizations have taken part today. Then if they're interested, we can involve them. Yeah. Okay.
Okay.
Yeah.
Okay, thank you very much.
Yeah. So I am from Wiltshire. Hello. I'm from Wiltshire in a specialized mental health unit with individuals challenging behavior. Yes, I find this very, very interesting.
Sorry, we can't hear. The connection is not good. Sorry, the connection is not good. Yeah.
Might be better to write it down on chat.
Yeah. Okay, we'll let Alan decide. So you can publicize this through your channel if anybody's interested to take part. Yeah. Okay.
Yeah.
Thank you, Alan and Robin, for inviting us.
No problem. Thank you. Good to see you again.
And we'll be in touch, you know, to see how we can help this and how we can use your materials, you know, in the future. Yeah.
Okay.
Okay.
Thank you very much.
I'll stop the recording now.
Thank you.